Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. We have a YouTube channel where all the lectures are available. You can view them at your convenience and you can download them as well. We also have a Telegram group which you can join to access all lecture related information. And we have the Google Drive which has all the PDFs of all lectures. And we have a master integration key by which you can navigate between the Google Drive and the YouTube. These are the disclaimers. And we are with phase 3, which is the recorded pathology lectures. And today we are with Pursue 4I, which is female genital system. And we are streaming from Medica, Kolkata, India. And the topic of the day is pathology of the vulva and vagina from ocular to molecular. And to talk on that, we have Dr. Subhalakshmi Sengupta. She's an MBBS, MD, FRCPATH. She's a consultant pathologist at the Medica Superspeciality Hospital, Kolkata, India, with multiple publication indexed in national and international journals. So I would request Dr. Subhalakshmi Sengupta to start her talk on pathology of vulva and vagina, ocular to molecular. So over to you, Dr. Sengupta. Thank you so much.
Hello all, I'm Dr. Subhalakshmi Sengupta, attached to Medica Superspeciality Hospital, Oncology Division, Kolkata. This is my first lecture of this series and I have divided into the following broad headings: the inflammation and infection affecting vulva, non-infectious dermatosis, cystic lesions, and finally the tumors. Now, what are the inflammatory conditions that occurs in vulva? They are mainly the Bartholin's abscess and hidradenitis suppurativa. Bartholin's abscess is the acute inflammation of the Bartholin's gland caused by aerobic and anaerobic organisms. Treatment includes excision, drainage, and proper antibiotics. Hidradenitis suppurativa also presents as painful subcutaneous nodules in areas specially containing the apocrine glands, like the vulva or the axilla. Initial changes is that of an abscess, which may progress to sinus tract formation or dermal scarring. Treatment is total excision of the involved area. Now, what are the infections that can affect vulva? They are mainly the HPV infection and HSV infections. Also, molluscum contagiosum is another infection that can affect the vulva. Now, HPV infection causes condyloma acuminata, also referred as genital wart. It is caused by HPV virus types 11 or 6. It presents as asymptomatic multiple papillary or papillar lesions in the vulva. Microscopically, what will you get? In the condylomata of the vulva, there will be a fibrovascular stalk, and the squamous epithelium will exhibit acanthosis, papillomatosis, hyperkeratosis, dyskeratosis, and a prominent granular cell layer. The viral cytopathic effect, termed as coilocytes, takes the form of cytoplasmic clearing around enlarged nuclei with irregular nuclear outlines and clumped chromatin. Now, what will you get in HSV infection? The next slide shows the ulceration of the lining squamous epithelium, and at the age of the ulcer, there are some keratinocytes which are multinucleated, showing nuclear molding and ground glass appearance, suggestive of inclusions of herpes simplex virus. There is no evidence of dysplasia or malignancy in the section examined. There is a tendency to overcall this condition as malignancy. So please be aware of this condition and do not overcall this as malignancy. Before coming to the non-infectious squamous lesions, I'd like to discuss the cystic lesions briefly. What are the cysts that you can encounter in vulva? They are mainly the Bartholin cysts lined by either stratified squamous or transitional epithelium. The keratinous cyst lined by stratified squamous epithelium having a prominent granular cell layer and containing flecks of keratin in the lumen, followed by the mucous cyst, which is lined by a single layer of bland-looking mucin-secreting columnar epithelium. Now, the non-infectious squamous lesions affecting the vulva are mainly the lichen sclerosus, lichen simplex, and other dermatosis. I'd like to discuss the lichen sclerosus in a little bit detail because this is a very common entity and you will encounter it in day-to-day practice. In this section, you can see the skin with loss of epidermis, hyperkeratosis, fibrosis of the superficial dermis with loss of adnexal structures. The superficial dermis appears pale and homogeneous. There is a prominent lichenoid-like reaction in the dermal-epidermal junction, often with eosinophils. There is no evidence of dysplasia or malignancy in this section. This is an exhaustive list showing the WHO classification of tumors of vulva. I will not go into details of each and every entity. I will pick and choose some of the tumors which are important and go through them. Now, what do you see in this slide? The section shows the skin showing hyperkeratosis, pseudoepitheliomatous hyperplasia, and in the dermis there is a tumor showing large polygonal cells having distinct cell boundary, abundant granular eosinophilic cytoplasm, and small uniform vesicular nuclei. No mitosis or necrosis can be identified in this section. Now, the diagnosis is that of a granular cell tumor. So what are the IHCs that you will ask for when you are suspecting a granular cell tumor? These tumors are positive for CD68, S100, NSE, CD56 and EMA. It is also PAS-D positive. It is a benign soft tissue tumor with neuroectodermal differentiation and excision is usually curative. What are the differential diagnoses that comes here? These are the atypical mycobacterium infection, xanthogranuloma and malakoplakia. Atypical mycobacterial infection will show AFB positive with the Zegan stain, and the xanthogranuloma will be S100 negative. Malakoplakia will have Michaelis-Guttman bodies which are S100 negative. Now, while reporting granular cell tumor, you must carefully look for the 6 features which will help you to classify whether this tumor is malignant, atypical or benign. What are the 6 features? They are the necrosis, spindling of cells, pleomorphism of nuclei, mitotic activity more than 2 mitosis per 10 high power filled, high NC ratio and pleomorphism. If you get 3 or more of this criteria, you will call this granular cell tumor as malignant. If 1 or 2 criteria are present, it is an atypical granular cell tumor. If none of these criteria are present, this is a benign granular cell tumor. Now, coming to the next entity, what you see here is a very well circumscribed dermal breast lesion having a maze-like glandular and papillary architecture without connection to the overlying epithelium. The glands are lined by an inner layer of cuboidal cells and an outer layer of myoepithelial cells. Mitotic figures are quite rare. The overall morphological features are consistent with a hydradenoma papilliferum, which is a benign adnexal skin tumor. This have excellent prognosis and complete excision is curative. Very rarely this entity can transform into malignancy. Now, coming to the next entity, this section from the vulval biopsy shows presence of single and small clusters of atypical cells scattered throughout the thickness of epidermis. These cells are large, have abundant pale cytoplasm, vesicular nuclei and prominent nucleoli. Dermis contains chronic inflammatory cell infiltrates. There is no evidence of invasive malignancy in this biopsy. What is the diagnosis? This is a case of extramammary Paget's disease without any evidence of invasive malignancy, at least in the section that I have shown you. But you must remember to cut deeper sections to rule out presence of invasive malignancy underneath. Now, extramammary vulvar Paget's disease can be due to the primary cutaneous, in situ or invasive adenocarcinoma, or secondary affecting the vulva, that is the manifestation of underlying rectal, anal adenocarcinoma, urothelial carcinoma, and rarely gynecological adenocarcinoma. So what is the recommended panel of IHC for distinction of primary and or the secondary Paget's disease? The primary Paget's disease will be CK7, EMA, CEA, CDFP positive, whereas negative for CK20. Now I'll show you a table which differentiates between various secondary Paget's disease. Now, what is the differential diagnosis that comes here? It is always the melanoma in situ. So you should also include S100, melan A and HMB45 in your panel. If it is a melanoma in situ or melanoma in radial growth phase, these cells will be S100 positive, melan A positive and HMB45 positive as well. So this is the table I was talking about. So the secondary Paget's disease, if it is from extension of a rectal adenocarcinoma, they will be CEA positive, CK7 negative, CK20 positive, EMA positive, GCDFP15 negative, GATA3 negative and PAX8 negative. Urothelial carcinoma will show CEA plus minus positive, CK7 positive, CK20 may or may not be positive, EMA positive, GCDFP 15 negative, GATA3 positive and PAX8 negative. The cervical or endometrial adenocarcinoma will be positive for CEA, CK7 positive, CK20 negative, EMA positive, GCDFP 15 negative, GATA3 negative and PAX8 positive. Now, coming to the next tumor. Cells have moderate amount of eosinophilic cytoplasm. No necrosis could be identified and overlying epidermis is quite unremarkable. So the diagnosis is that of a dermatofibrosarcoma. And what are the IHC that you will use to confirm the diagnosis? These tumors are CD34 positive, CD31 SMA Desmin S100 STAT6 CK and P63 negative. They have a typical translocation cholia1A PDGFB beta. Prognosis: DFSP is a locally aggressive tumor with the potential for local recurrence in case of incomplete excision, but usually do not have any metastatic potential. These tumors may transform into high-grade fibrosarcoma. So what are the differential diagnoses that comes here? Leiomyoma, leiomyosarcoma, dermatofibroma, solitary fibrous tumor, and MPNST. Now coming to the next set of lesions of vulva. So what do you see here? It reveals a poorly circumscribed hypercellular lesion with myxoid stroma and abundant vasculature infiltrating the fibroadipose tissue. By immunohistochemistry, the lesional stromal cells are positive for Desmin, ER, PR, and HMGA2. So the diagnosis is that of an aggressive angiomyxoma. What are the differential diagnoses that comes here? These are the superficial angiomyxoma. Firstly, these are the lesions mostly affecting in the extragenital sites. They are well circumscribed grossly. Epidermoid, squamoid or basaloid epithelial elements in about 20% of these cases. There may be stromal mucin clefts with neutrophils, and these tumors are usually ER, PR, HMGA2 negative. The next entity which comes into the differential diagnosis is the angiomyofibroblastoma. These tumors are well circumscribed and non-infiltrative. They have alternate hypocellular and hypercellular areas, plus the tumor cells are hypoepithelioid to plasmacytoid, and they tend to cluster around small to medium-sized non-hyalinized thin-walled blood vessels. These tumors lack the rearrangements for HMGA2 and are ER positive, PR positive, and Desmin positive. The next entity which comes into differential diagnosis is the cellular angiofibroma. These tumors are usually located in the subcutaneous areas and very rarely in the dermis. They are also well circumscribed and contain small monotonous spindle cells with bland fusiform nuclei. They are arranged in short fascicles, and bland multinucleated cells are quite common. The stroma is usually myxoid, edematous, fibrous, or even hyalinized, and there are abundant medium-sized thick-walled hyalinized blood vessels interspersed with short wispy collagen bundles. The tumor cells are positive for CD34, as you can see in the middle picture. They are also ER positive and PR positive. This table contains all the differential diagnosis along with the morphological characteristics, and also includes the entities like myxofibrosarcoma, myxoid liposarcoma, myxoid neurofibroma, cellular angiofibroma, which I have discussed earlier in details. Now, the next entity is that of atypical melanocytic nevi of the genital type, which you need to be aware of because it is often misdiagnosed as melanoma, when it is actually not. This tumor typically affects the vulva of young women, and there are three histological patterns: nested, discohesive, and crowded. The nests may be perpendicular or parallel to epidermal surface. The melanocytic cytologic atypia ranges from mild to severe. There may be focal pagetoid spread, most often centrally located, and there is a large underlying mushroom-shaped dermal component with maturation. This maturation is very important to differentiate between a nevus and the melanoma. Dermal mitosis is uncommon but may be present up to 2 per section, per tissue section. Lymphocytic infiltrate is inconspicuous. So what are the differential diagnosis? That is the dysplastic nevus and of course the melanoma. Melanoma primarily affects the postmenopausal women, lacks symmetry and maturation. There will be greater cytologic atypia, increased dermal mitosis, even atypical mitosis may be seen. There will be pagetoid spread of melanocytes, which is more pronounced than that of the nevus. There will be a plaque-like lymphocytic infiltrate if radial phase melanoma is there, and there may be diffuse eosinophilic fibrosis with angiogenesis. Now, what are the types of biopsy specimens that you can encounter in your day-to-day practice? There may be small biopsies, excisional biopsies, or vulvectomies. Now, small biopsies are usually punch biopsies. The excisional biopsies, these should be handled in the same way as other excisional biopsies of skin. That is, you need to ink all the margins, both the cutaneous and the deep, and take sections perpendicularly to the epithelial surface. The separate cutaneous margins should be clearly designated, and if you do not get any lesion, be prepared to submit the entire specimen in order to rule out or confirm invasive disease. Now, what are the important issues to address in your surgical pathology report on vulvectomies? What is the type of vulvectomy that was performed, whether it is a partial or a total, and what are the structures present? And where is the tumor located? It is unifocal or multifocal. What is the size of the tumor? You have to document that in centimeters. What are the histological types and grade of the neoplasm? What is the maximum thickness, both grossly and microscopically? What is the maximum depth of invasion? This is measured microscopically. Does the tumor extend into adjacent tissues, grossly or microscopically? Does the non-neoplastic portion of the vulva show any pathology, grossly and microscopically? And also, does the tumor involve any of the lymph nodes? It is usually prudent if you ask the surgeon to orient the specimen for you. So you have to orient the specimen as if viewed in situ with the inguinal wing superior and lateral. You have to ink all the cutaneous and soft tissue margins, including the tip margin. Ink the vaginal margin with a separate color. Document the size of all the lesions and section with full thickness incisions perpendicular to the epithelial surface. Dissect the inguinal wings for lymph nodes and maintain their right and left orientation. Submit sections of tumor to demonstrate maximum tumor thickness. At least one section you must take, taking the maximum tumor thickness, along with the nearest margins, whether it's a vaginal margin, cutaneous margin, or deep margin. Note and take section if any other skin lesions are present. You have to submit all the lymph nodes along with section from the uninvolved skin, including clitoris, perineum, and contralateral labia majora and minora. Again, I showed you this slide previously. This is a WHO list of the vulvar tumors, of which I'll discuss the vulvar squamous carcinoma in details along with its precursors. The usual type VIN. What happens here? The epidermis is usually thickened with parakeratosis and hyperkeratosis. At low power, there is loss of cell maturation with nuclear hyperchromasia, increased mitotic figures, pleomorphism, and high NC ratio. UVIN has been divided into basaloid, undifferentiated, and warty or condylomatous subtypes. Basaloid VIN represents a flat lesion composed of small to uniform cells resembling basal cells with high NC ratio, minimal coilocytotic changes replacing the entire thickness of the epidermis. On the other hand, the warty VIN shows acanthosis with wide and deep retilages and prominent coilocytotic changes. Now, these are HPV associated, and you will get diffuse block positivity for P16. DVIN, what are the histological findings? It is usually very subtle and not easily recognized, and therefore often misdiagnosed as a benign dermatosis. DVIN is characterized by a thickened parakeratotic epithelium with elongation and anastomosing retilages. Marked cellular atypia is confined to the basal and parabasal cells of the epidermis, comprising abnormal squamous cells with atypical mitosis in the basal layer. The upper epithelium is highly differentiated with epithelial maturation in the superficial layers. Characteristically, keratinocytes in the basal layers show abundant eosinophilic cytoplasm with prominent eosinophilic nucleoli and pronounced intercellular bridges. Dyskeratotic cells are usually present throughout the epithelium. Keratinocytes in the mid to superficial layers may show focal or no atypia at all. Changes consistent with lichen sclerosus or lichen simplex chronicus can be found adjacent to the DVIN or elsewhere in relation to the resection specimen. The lowermost picture shows P53 staining, which is usually in the basal cell layer and shows overexpression, that is mutated type. This table shows broadly the differences between the HPV-associated UVIN and HPV-independent DVIN. UVIN, in nutshell, occurs in younger age group, in the smokers with history of prior cervical dysplasia. It may be multifocal and less aggressive. There is less than 10% progression into squamous carcinoma. Histology may be warty and basal. P16 is block positivity, shows block positivity. HPV-independent DVIN occurs in elderly, associated with lichen sclerosus or lichen simplex chronicus. It is usually unifocal, more aggressive with 30 to 90% progression into the squamous carcinoma, and histology is keratinizing type. You will get P53 mutation, which is usually depicted by overexpression, especially in the basal cell layer. Now, interpretation of P16 and P53 is very important. If you remember what I showed you earlier in UVIN, there is diffuse block positivity for P16, that you will get almost the entire slide will be positive for P16, both the nuclei and the cytoplasmic. And about P53, there is the different types of patterns, rather staining of P53. Now, what is the normal or wild type P53? There will be just scattered positivity, nuclear positivity for P53. And what are the mutant type P53? There will be either basal overexpression, parabasal diffuse overexpression, or P53 staining may be totally absent, which we call this null mutation, or there may be cytoplasmic staining, which also denotes P53 mutation. Now, mid-epithelial basal sparing type of staining is considered as wild type P53 and not a mutant P53 type. Another far less common form of HPV-independent lesion is now called differentiated exophytic vulvar intraepithelial lesion, or DEVIL. This lesion demonstrates vericiform acanthosis, hypogranulosis and cytoplasmic pallor of the cells. Unlike HCIL, this DVIN DEVIL lacks cytologic atypia. DEVIL has been associated with P16 negative, P53 normal carcinomas, including verrucous and conventional squamous carcinoma. DEVIL is characterized by negative or patchy P16 and wild type P53. Like the precursor lesions, invasive squamous cell carcinoma is also divided into HPV associated and HPV independent. HPV associated squamous carcinomas are similar to squamous cell carcinoma at the other sites. They may be a warty-like tumor, ulcer, plaque, or rarely present as erythematous rash. Now, this entity, superficially invasive squamous cell carcinoma, what are the criteria to call it a microinvasive squamous cell carcinoma as it was previously called? The tumor size should be less than equal to 2 cm and confined to the vulva. There will be stromal invasion of less than or equal to 1 mm, and there should be no metastasis to the lymph nodes. HPV-independent squamous carcinoma usually presents as exoendophytic, well-circumscribed tumor composed of closely packed papillary structures lined by well-differentiated stratified squamous epithelium with minimum cellular atypia. By definition, no invasion by clusters or single tumor cells should be present. Epithelium demonstrates prominent acanthosis with expansion of ridges that push into the dermis or the submucosa with rounded borders or a broad front. In tangentially cut sections, the tumor is composed of large back-to-back nests of well-differentiated squamous epithelium. The superficial lining shows hyperkeratosis and parakeratosis. The cells have abundant pale eosinophilic cytoplasm with low NC ratio, no or mild nuclear pleomorphism, and basally located mitotic figures. Lymphovascular and perineal invasion are extremely rare. While reporting a vulvar carcinoma, you need to mention in your report the histology, the grading of the tumor, the size of the tumor, both grossly and microscopically, depth of invasion, margins of invasive component, lymph node involvement. In the lymph node involvement, you need to record the size of the metastasis, if there are isolated tumor cells present, or if there is extranodal extension, LVSI and the perineural invasion, presence of VIN in the margin or in the adjacent areas. Now, how to measure the depth of invasion? There has been a recent change in the criteria for measuring the depth of invasion. The WHO recent criteria says the depth of invasion is measured from the basement membrane of the deepest adjacent dysplastic tumor-free reach or the nearest dysplastic peg to the deepest point of invasion. This table shows broadly the differences between the HPV-dependent and the HPV-independent squamous carcinoma. HPV-dependent squamous carcinoma is usually in the younger, less than 65 years old, associated with high-risk HPV and smoking. Precursor lesions are usually present, which is the HCIL or the UVIN. The relative percentage of all precursor lesions is majority, approximately 90%. Progression to squamous cell carcinoma by precursor is 3 to 9%. Whereas in HPV-independent squamous carcinomas, these carcinomas usually occur in more than 65 years old and associated with inflammatory conditions like lichen sclerosis. They're associated with precursor lesions like DVIN, and the progression to SCC by precursor is almost 33%. The following slides will show the summary of the latest 2021 FIGO staging system for vulvar cancer and its comparison with the 2009 FIGO staging system. Until now, FIGO staging of vulvar cancer has been based mainly on the clinical and pathological examination. In the 2021 staging system, this approach has been revised to allow imaging where available to assign stage. What are the salient changes? There is a new method has been adapted for measuring the depth of invasion, which I have described previously. Stage 3A now includes extension to upper to third urethra or vagina or to bladder or rectal mucosa which were previously classified as stage 4A. Any number of involved lymph nodes as long as maximum dimension of METs is less than equal to 5 mm is stage 3A. Any number of lymph nodes if size of METs more than 5 mm is 3B. And lymph nodes containing macro and or micrometastasis are considered involved. Isolated tumor cells do not change the stage, but their presence should be recorded. This is stage 1 showing a vis-a-vis comparison with the 2009 FIGO staging and 2021 FIGO staging. No change in criteria, just the change in the method for measuring the depth of invasion. Now stage 2, in 2009 FIGO staging, tumor of any size with extension to adjacent structures, that is 1/3 lower urethra, 1/3 lower vagina and 1/3 of lower anus with negative nodes were included in this stage, and in 2021 it remains the same, no change. Stage 3, in 2021 it includes the tumors which affect but invades the upper 2/3 of urethra, upper 2/3 of vagina, bladder mucosa or rectal mucosa. All previously were under stage 4A. Any number of lymph nodes as long as less than equal to 5 mm METs should be included here. 3B now includes any number of lymph nodes if size of METs is more than 5 mm. Now excludes 3 or more lymph nodes if size is less than equal to 5 mm, now considered as 3A. 3C, no change from 2009 classification. Any distance metastasis is considered as 4B. So these are the references. Thank you very much.